you again so much. We'll bring up our last and final speaker, Richard Allman from the Geriatrics Extended Care Department of Veteran Affairs, who'll be talking with us about the relationship between nutrition and mobility.
Thank you.
I'm honored to be here today. Thank you for inviting me. Program planning, Julie Locker and Gordon Jensen. I think you guys were responsible for this. I tried to get out of it, but they wouldn't let me. So here we are. So we'll do the best that we can. Before I came to work for the Department of Veterans Affairs about 21 months ago here in Washington, and who's counting, I worked for 27 years at the University of Alabama at Birmingham and was on faculty there. And I was supported by the National Institute on Aging and the Department of Veterans Affairs. And most of the comments that I'll talk about today will come from studies that we did with that support. What I'm going to try to do is describe the prevalence of low body mass index, high body mass index, and nutritional risk factors among community-dwelling older adults. Give you some cross-sectional associations between BMI and nutritional risk among with community mobility as measured by the life space assessment, which I'll tell you more about. Provide you some prospective data on significant and independent associations between these measures with life space mobility changes over up to a 4-year period of follow-up. And actually, just as I was coming, I realized, oh, I do have some interesting 8.5-year follow-up data, so I'll show you that this afternoon. So for those of you who got to see some of those other slides, you know that Alabama is right in the Deep South, where we are the capital of health disparities. And we have a large proportion of individuals that are African American. And so that gives you a great opportunity to look at a wide spectrum of socioeconomic status and racial ethnic diversity. And so we conducted a study of aging there between 1999 and 2009. That's an observational study of health and mobility. And we selected 5 counties to target, 3 of which have very high proportions of African American population, Pickens, Hale, and Bibb, who are rural counties, and then 2 urbanized counties, Jefferson County and Tuscaloosa, the pink counties on the map. And Jefferson County is where the University of Alabama at Birmingham is located. Tuscaloosa County is where the University of Alabama is, where the football team is. So there you go. But this study oversampled males, African Americans, and rural residents. Participants were selected using a stratified random sampling of Medicare beneficiaries living in these counties. We did extensive in-home assessments between 1999 and 2001. Whoops. And the assessments included measures of health, life space mobility, nutritional risk, and body mass index. We used telephone follow-ups every 6 months for up to 8.5 years to ascertain life space and mortality outcomes and a number of other measures. The primary outcome measure for this study was life space as measured by the UAB life space assessment. And in this measure, and we actually forward to the conference organizers a copy of this instrument if you want to look at it in more detail. But we are simply finding out in the previous 4 weeks where people have moved about in their environment. We asked about how frequently they went and whether or not they needed any assistance or used any assistance. We asked them about whether or not they usually used assistance with any kind of assistive device or from another person. And we would ask them about whether or not they left the room where they slept, whether they got to outside of their house, whether they got to the yard or into their neighborhood, to their town, or outside of their town. We developed a scoring algorithm that we correlated with observed physical performance measures and demonstrated that a composite measure that incorporated distance, frequency, and reported use of assistance seemed to correlate best with observed physical performance. And subsequently, we showed that the test-retest reliability of this measure showed an interclass correlation coefficient of about 0.96. And subsequently, we found that this measure predicted mortality, nursing home admissions, cognitive change, healthcare utilization, and heart failure populations. And a group in Japan have shown that this measure predicts IADL, or instrumental activity of daily living, a development of difficulty in cohorts without initially any disability. This little figure shows the average score at different independent life space levels. And what we mean by independent life space levels or zones is that if you're able to get to that zone or beyond that zone without help from a person or equipment, then you're independently able to get there. And so bedroom would be zone 0 and home would be zone 1, and you can see on this figure the score is around 20. So there's not much variability for individuals that are homebound, so that would correlate to a composite score of about 20. If they're able to get out to the yard without assistance from a person, the score would be around 30. If they reported in the previous month that they usually could get to their neighborhood without assistance from a person or equipment, the score would be about 44. Going to town would be a score about 60, and out of town would be a score about 80. And gives you a general idea of the distribution of the score. In addition to this measure of mobility, previous research and most of the other research on nutrition and mobility is focused on specific mobility-related tasks, like climbing stairs, walking a certain distance, difficulty with transfer, etc. Well, this measure is a measure or reflection of mobility that reflects participation in one's community or neighborhood, as we've talked about, the environment. In terms of the nutrition measures that we are going to focus on this afternoon to talk about related to life space, we looked at weight and height, body mass index, and the nutrition risk index, which is a form of the determine index. And in this particular study, we had one question that we didn't ask, and that was about vegetables, fruits, and milk intake, but all the other items in the determine index were assessed. So the score ranged from 0 to 19, and a score of greater than 6 represented high risk. And these are the questions, those of you who know about the determine index would be familiar with these, but these include questions about do you have appetite, challenges, eat one meal or irregularly, 3 or more alcoholic drinks per day, problems with your teeth, mouth, or swallowing, if you're having a difficult time paying for basics, 3 or more over-the-counter medicines or prescription drugs, if you live alone, if you've lost or gained 10 pounds without trying, or if you have difficulty eating, preparing meals, or shopping. Again, the score ranged from 0 to 9, with a greater than 6 correlated with high nutritional risk or reported to correlate with high nutritional risk. So I'll show you some data from this particular study. I always like to show this slide when I talk about the UAB study of aging. It was, again, a random sample of community-dwelling older adults 65 and above living in West Central Alabama. And there's a wide spectrum of socioeconomic diversity within racial and ethnic groups, and lots of differences in built environment. So a very interesting group of individuals to study. It could be a friend, a neighbor, or a relative for many of us in the room. And this shows you the baseline characteristics. By intention, everybody was over age 65. It's a random sample of Medicare beneficiaries. The average age was 75, I'm sorry. And we can see by intent, we had half were African American, half were female, half lived in rural counties. And it turned out about half were married. Again, because of the location, many had low education, 20% less than a 7th grade education, but 50% did have a high school or greater education, and a wide diversity of incomes. You saw on the previous slide a list of common chronic conditions, and again, I think it was something like 90% or higher of this particular population had one or more chronic conditions, and as you would expect in a population of people over the age of 65, the prevalence of these chronic conditions is very high, in contrast to the one where you were looking at 18 above and the hypertension prevalence was like 25%, 71% of these individuals had a diagnosis or were taking blood pressure medicines, and you can see the prevalence of the other common chronic conditions in this group. We did do measures of cognitive assessment, including the mini mental status exam, a measure of depression, the Geriatric Depression Scale, the GDS, and we also we did a standardized questionnaire of physical activity. There was low physical activity, relatively high prevalence of depressive symptoms, and a high prevalence of cognitive risk. This shows you the distribution of the life space score that I described for you, and one of the reasons why we used it as a primary outcome is because it has a normal distribution. Another reason why we used it is earlier the Institute of Medicine had done a workshop on disability and suggested, well, we have a lot of measures that reflect mobility-related tasks, but we don't have a lot of measures related to function in the participation domain, and we felt that the life space was contributing to a measure of mobility, where people are going, how frequently they go, whether or not they need assistance in a domain of participation that would require the capability of carrying out multiple different mobility-related tasks. And the higher the score, the more likely is that these people are using or independently using public transportation, driving their own vehicle, having the capacity to drive outside of their neighborhood. That might be very important for acquisition of food and being able to have a diverse diet. The distribution of body mass index in this particular sample, you can see 31% of them met the criteria for obesity with a BMI of greater than 30. 7% had a low body mass index of less than 20 in this particular sample. And this shows you the prevalence of nutrition risk factors. The most common risk factor for nutritional risk in the population was reported to be living alone, but you can see nearly a third of individuals, or at least a quarter, reported polypharmacy, weight gain or weight loss that was unintentional, and ADL or IDL difficulty. Similarly, we had about 18% of the people having trouble with their appetite. You see that the prevalence, again, of BMI greater than 30 was slightly greater than 30%, BMI less than 20, about 8%, a nutrition risk index of greater than 6 was nearly 10%. This slide shows the correlation of BMI and independent life space mobility category. So again, the 0 category here would be individuals that in the previous month could not get out of the room where they slept without help from a person or special equipment. While category 5 would be somebody who had reported in the past month they were able to get out of their town without help from another person or without any special equipment. And you can see that 40% of individuals who were in the lowest mobility category had a body mass index of greater than or equal to 30. In contrast, about 75% of people in the highest category did not have reached the category of relationship of with body mass index of greater than 30. So there's a correlation here, a cross-sectional association between BMI and life space mobility. This shows the correlations in a cross-sectional manner of independent life space level. That is, the higher the level, the greater the community mobility for individuals with different risk factors for nutrition risk that are in the nutrition risk index. And you can see lower mobility was associated with poor appetite, mouth problems, pain for food, problems, living alone, a history of weight loss or gain that was unintentional, functional difficulty, and or more medications. Meal frequency and alcohol use were not significantly associated with mobility level. And this summarizes what, if you put all those risk factors together into the nutrition risk index, how did the independent life space correlate with nutritional risk? And again, the yellow and the red components of these bars reflect the percentage of individuals who had scores of greater than 6 on the nutrition risk index. And you can see that nearly 50% of individuals who had the lowest level of independent life space had a body mass index, were in the lowest mobility category, and vice versa. 90% of the people in the highest mobility category had a low risk for nutrition problems. When we look to see whether or not this association between mobility and the nutrition risk index of greater than 6 was an independent association, we found that there was a 2 to 3-fold increased odds of having a high nutrition risk score after adjusting for other socio-demographic factors, medical conditions, BMI, smoking, and exercise if individuals could not or did not report getting out of their neighborhood, their home, or in their yard in the previous month without help from a person or specialized equipment. Now, this slide reflects a longitudinal analysis looking over 4 years, the change in life space score, the composite score, by BMI over 4 years. In the bottom line reflects individuals with a BMI of, and I guess my glasses aren't as good as I'd like, are less than 18.5. And the very top bar at the baseline suggested a BMI of greater than 18.5 and less than 25. The next one is kind of the normal range, 25 to 30. I guess if I had my laser pointer, I could show you these. So this is the lowest body mass index. So you can see at baseline there's a spread of the life space score, but really there's no significant difference in the rate of decline among these different body mass index. In this particular analysis, there seems to be some indication that low body mass index is having a higher accelerated loss of mobility than the other measures in this particular analysis. Now, when you look at risk factors for nutritional risk, we particularly focused on, and I think Julie did this one, you look at the longitudinal data related to history of weight loss and what happened subsequently over 4 years with life space. And you can see this bottom line here. These are individuals who reported an unintentional weight loss of 10 pounds or more in the previous, I think it was 6 months, and you can see an accelerated decline in life space. And these are individuals with intentional weight loss, and these are people with no history of weight loss. And we saw no difference, so no increased risk or no decreased risk with individuals who reported intentional weight loss versus those who didn't. But we saw a clear-cut association, independent association prospectively of those who reported weight loss before at the baseline. We've followed this population over 8.5 years, and we're able to look at racial differences in predictors of life space change over that period of time, adjusting for baseline life space. And I just would focus here that when we looked at body mass index in these models, and again, these models are adjusting for other predictors, and they all have the same variables in them, but these were the significant variables for the African Americans and the whites. And again, this is a pretty balanced sample in terms of numbers, but we found that body mass index of less than 20 and greater than 30 were predictive of life space decline in African Americans. A body mass index less than 20 was predictive in whites. It was interesting to us that basically, except for BMI less than 20, all the others were different. And again, we've already talked about how income and transportation difficulty can be important in health and measures of health in older adults, and it's particularly important here, and it may reflect a decreased variability in these measures among the white older adults in our sample. So, what we found in these studies is that the elevated body mass index is more common than a BMI less than 20 or an elevated score on the nutrition risk index. higher BMI is associated with lower independent life space mobility. However, this association was not significant after adjusting for other factors. BMI is not associated with more rapid declines in life space mobility after 4 years. But the nutrition risk factors and nutrition risk index are associated with lower life space mobility. An elevated nutrition risk is significantly and independently associated with lower independent life space mobility. In prospective analyses, unintentional weight loss is significantly and independently associated with accelerated declines, and after 8 years of follow-up, body mass index of less than 20 and over 30 are predictive in African Americans, but BMI over 30 is predictive. BMI less than 20 is predictive in whites, but not African Americans. So there. Thank you. That was close.